Hi there, my name is Joan Harris and I'm instructor for the ACCN program. This PowerPoint will discuss the assessment and management of delirium in the ICU. Delirium has come to the forefront of our attention in the ICU as a serious condition with far-reaching effects. Delirium is defined as an acute disturbance in mental status. It is characterized by inattention, disorganized thinking, and an alternating or fluctuating level of consciousness. Delirium results from an underlying pathophysiologic condition. In many instances, it is believed to be preventable and reversible. Delirium is sometimes referred to as acute brain failure in an attempt to prevent it from being dismissed as an expected and inconsequential complication, especially in the critical care, where more common terms have included ICU psychosis or sundowner syndrome. Our responses in the past have ranged from amusement — these patients often have strange hallucinations that make for amusing anecdotes — to irritation as the patient is agitated and trying to get out of bed, pulling at lines, that sort of thing. Often our response would be to sedate and restrain these patients. In short, our approach to delirious patients in the ICU in the past has not taken into account the underlying pathophysiology and long-term effects of delirium, or the terrifying nature of this condition for both patients and families. Typically, when we think of delirium, we think of the agitated and hallucinating patient. This is one of the subtypes of delirium, but is actually not the most common type. It is, however, the most easily identified as delirium because of the outward manifestations of the symptoms. Hyperactive delirium is characterized by agitation, restlessness, being emotionally labile, and pulling at lines and tubes. Hypoactive delirium, which is believed to be much more prevalent, is challenging to identify, especially in the mechanically ventilated patients, because of the lack of outward symptoms. These patients often have a flat affect, are withdrawn, lethargic, and apathetic with decreased responsiveness. This can mask the other features of delirium, such as hallucinations and disorganized thinking. The final subtype is characterized by fluctuating between hypoactive and hyperactive delirium. Attempts to elucidate the underlying pathophysiology of delirium have been complicated by the complexity of the pathophysiological processes. In short, delirium represents acute brain dysfunction with multifaceted, multifactorial potential causes. Here is a list of some of the common causes of delirium that we see in the ICU. These include acid-base disturbance, electrolyte imbalances, direct brain injury, disease pathology such as hepatic encephalopathy, renal failure, septic shock, congestive heart failure, ARDS, and multi-organ dysfunction syndrome. Medications can also be involved, particularly benzodiazepines, anticholinergics, opioids, and barbiturates. Drug and alcohol abuse also plays a role in causing delirium. Sensory deprivation and overload, which is along with immobility, prolonged sleep deprivation, and prolonged mechanical ventilation, are all common occurrences, unfortunately, in the ICU, so you can see why our patients at a very high risk for delirium. This list is in no way comprehensive, and more often than not, more than one factor is contributing at any one time. For example, a patient with an existing traumatic brain injury may develop delirium directly related to the injury, as well as the sequela of acid-base imbalances, medications, immobility, etc., etc. Awareness of the potential causes can assist us with prevention and management of delirium. There have been many studies that have looked at the outcomes of patients who have delirium while in the ICU. These studies are sobering in their severity and long-term indications. Delirium has been shown to increase both ICU length of stay and overall hospital length of stay. It increases the time the patient requires mechanical ventilation, all of which leads to an overall increase in costs and unnecessary use of valuable resources. More importantly, delirium increases ICU mortality, and there is a 3-fold increased rate of death at 6 months. Finally, delirium has been associated with long-term cognitive impairment, which has led patients to being unemployable and have poor reintegration into home life. So we know that delirium is bad. What can we do about it? Well, in order to treat delirium, we need to be able to identify patients who are suffering from delirium. Screening tools are necessary because in the absence of a validated tool, delirium is undetected in greater than 65% of the ICU patients. The most commonly accepted validated tools are the Intensive Care Delirium Screening Checklist, or the ICD-SC, and the Confusion Assessment Method for ICU, CAM-ICU. So to start with, regardless of the tool that's being used, step one should always be the assessment of the patient's level of consciousness. There are two scales that are more commonly used in the ICU. They are the Richmond Agitation and Sedation Scale, or RASS, and the Riker Sedation Agitation Scale, also known as the Riker Scale, or SAS. If the RASS is less than or equal to -4, you will not be able to assess the patient for delirium. This would be equivalent to less than or equal to 2 with the Riker scale. If the RASS is greater than -4, then you may proceed with the assessment. Again, this would be the equivalent of greater than 2 with the Riker scale. Once we have determined that our patient has delirium, we need to do something about it. When managing delirium in the ICU, it can be helpful to consider the cause, and one memory tool that can be helpful is stop and think. Stop refers to the need to look at stopping any medications that may increase the risk of either developing or worsening delirium symptoms. Of particular importance is any sedating medication such as benzodiazepines. The use of sedation and analgesic protocols, whose aim is to ensure the least amount of medications is used to keep the patients comfortable, have been shown to be effective in reducing delirium. The acronym THINK looks at other factors that can cause or worsen delirium. T stands for toxic situations, so congestive heart failure, shock, dehydration, deliriogenic medications, organ failure, all can put the patient at risk or become vulnerable for delirium. H is for hypoxemia. I is for infection and immobilization. We'll talk more about early mobilization in ICU patients later in this presentation. Non-pharmacological inventions, and we're going to discuss that as well in more detail, and then looking at potassium or electrolyte problems. All of these should be addressed and properly managed before any pharmacological additions to the medications should be made. So let's talk about some of the non-pharmacological strategies. So orientation. So it's really important that the patient maintain orientated to person, place, and time. Some of the methods of trying to improve this have been having a whiteboard or some sort of indication of what time it is, what month it is, who's taking care of the patient, so maybe the names of the nurse and the physician and the respiratory therapist and other healthcare providers, having family available to talk with the patient to keep them orientated to their loved ones. It's really important that if the patient is showing disorientation, if they're incorrectly answering questions, that we make sure that we give them the correct information. Cognitive stimulation. So again, we rely on family a lot for this to just keep them engaged in their environment. In some cases, TV can be unacceptable. If there's the potential for other activities, this has been shown to help prevent delirium. Sleep protocol, it's very difficult to sleep in the ICU. It's very noisy. There's constant interruptions with assessments and blood work, etc. So trying to develop protocol where the patient is sort of tucked in 10 or 11 at night, and then given a longer period of time before interruptions, 4 to 5 hours if possible, coordinating care with other healthcare professionals so that during that time they would not be interrupted, keeping the lights off, those types of things, if there's possibility of decreasing the noise. All these things have been shown to be helpful. Early mobilization is a huge one. We've demonstrated in many studies that getting patients out of bed early and getting them moving, working with physiotherapy, is extremely important to try and mitigate delirium. De-intensification, so removing invasive lines when we don't need them anymore, trying to stay away from restraints. Sensory enhancement, making sure patients have access to their eyeglasses, hearing aids if they need those things. Early correction of dehydration, pain management protocols, and then just generally minimizing unnecessary noise and stimuli. So those are some of the non-pharmacological strategies. Now we're going to look at things that we can do pharmacologically. When looking at pharmacological strategies, the trend now is more towards removal of medication than adding new ones. Increased scrutiny has recently been placed on appropriate titration of sedative and analgesic medications in critically ill patients, especially those being treated with mechanical ventilation. Patient comfort should be a primary goal in the intensive care unit, including adequate pain control, anxiolysis, and prevention and treatment of delirium. However, achieving the appropriate balance of sedation and analgesia is challenging. Without rationale and agreed upon target levels of sedation, it is likely that different members of the healthcare team will have disparate treatment goals, increasing the chance for iatrogenic complications and potentially impeding recovery. Antipsychotics such as haloperidol and risperidone are commonly used to treat delirium, especially of a hyperactive nature. However, the PAD, or Pain Anxiety Delirium Guidelines, have no evidence for or against their use. Dexmedetomidine, an alpha-2 agonist, has shown promise in reducing the amount of sedation required for delirious patients, which may reduce the length and severity of delirium, but its use in Canada is relatively new. Ultimately, the best pharmacological treatment is patient-oriented, goal-directed sedation. So in conclusion, there is a high incidence of delirium in the ICU, depending on the patient population, anywhere from 20 to 75%. Delirium is not a benign pathology with evidence of increased mortality and length of stay, as well as long-term cognitive and functional deficits. In order to manage delirium, we need to recognize it, and the ICD-SC and CAM-ICU are two validated tools that identify delirium. There are many strategies for managing delirium, and the STOP and THINK acronym can help us identify potential causes and treat appropriately. There are some pharmacological interventions that are appropriate, such as antipsychotics and alpha-2 agonists, but in many cases it is the removal of medications that ultimately produces better results. Awareness of the effects of analgesics, sedatives, and hypnotic medications on our patients can help and prevent and treat this insidious pathology.